Hi, I am so sorry about this super long hiatus from putting up anything on our YouTube channel. But I have an extremely good excuse. We are conducting a 2 day workshop on psychological distress and cancer on the 30th and 31st of January, so basically this coming weekend. And my team and I have been super busy with arranging for things relating to this workshop, and it's been pretty hectic because of it. So unfortunately, I've been unable to put together any talks or anything like that on the YouTube channel. But I promise you that we'll be a lot more regular once this workshop is done and we all catch our breath. But for now, I've got a really short talk to present to you today, which is called Mirror, Mirror on the Wall, What's the Best Strategy for Them All? Diabetes Compliance During Ramadan in Hyderabad, India. This study is a collaboration between my team, which specializes in health psychology, Dr. Haripriya Narasimhan's team, which specializes in anthropology, and Dr. Rakesh Sahai's team, who are diabetologists or endocrinologists. This study just came about because Rakesh, me, and Haripriya were chatting one day, and we were talking about issues relating to diabetes adherence in Hyderabad. What was very specific or very culturally, driven. That was unique also within the Hyderabad context. And Rakesh was telling us how during the Ramadan period, it gets really difficult to manage diabetes compliance on the patient's part. And it's important to also note that Osmania General Hospital is very close to Charminar, and it is one of the more densely populated with Muslims kind of an area. So Ramadan, and diabetes compliance during that time is especially important within that region. So Haripriya and I got along and started thinking about how do we approach this from a research POV, and then eventually scale it into an evidence-based, perhaps intervention or program. But first, obviously, we needed to understand what our sample or what are the patient's experiential aspects of diabetes compliance, right? So we used a mixed methods model, and where Haripriya's team dealt with the qualitative aspects of the study, and my team dealt with the quantitative aspects of the study, and we were looking at compliance. From an experiential point of view, but also from an expectations and perceptions point of view. So, just to give you a quick background about diabetes in Ramadan, Ramadan is the ninth month in the Islamic calendar, usually lasts between 29 to 30 days, and it's based on the lunar calendar, by the way, so it's based on the moon. And during the Ramadan season, Ramadan period, people abstain from food, drinks, smoking, sexual activity, indulgences from sunrise all the way through to sunset. And research has shown that effects of fasting on diabetes can be quite wide ranging, in that it could alter the blood glucose levels, leading to diabetes related complications. And interestingly enough, there's been research that's reported that there is an increase actually in the dietary consumption of, high fat, high carb, high protein kind of diets during fasting, which led to an increase in body weight actually after the fasting period. So, owing to the importance of diabetes-related adherence and compliance during the Ramadan season or time, there has been an international meeting on diabetes and Ramadan recommendations in 1995, which had proposed two very important recommendations. One was that exemptions needed to be made for patients with type 1 diabetes and high-risk patients. So, patients that have unstable type 2 diabetes, with complicated diabetes, or pregnant with diabetes, or elderly people with diabetes. The other thing is that people who were fasting needed to be regularly monitoring their diabetes as recommended by the physician, which was before, during, and after Ramadan, to make sure that their diabetes complications are not persistent or have not occurred. It's also important at this point to remind you, if you don't know already, but Ramadan is also during the Ramadan season. It is allowing for exemptions as it is. So the Islamic scriptures do allow for people with complications or issues to exempt themselves from fasting. Nevertheless, patients with diabetes are found to be fasting during Ramadan, and that's fine as long as the physicians and the patients are adhering to these recommendations that you can see on your screen. So, we were reading all this literature on Ramadan and diabetes and these recommendations, and we were thinking that, yeah, it looks like patient-physician communication on diabetes management during Ramadan is crucial in diabetes adherence. So, what we found interesting when we started looking at patient-physician communication, which is also both Haripriya and my research areas of expertise and interest, we do know and we did find that there's research that supports the idea that physicians are somewhat ill-equipped or not confident enough in understanding and including cultural or religious beliefs of patients within their treatment modalities and recommendations. So, as the Wiseman study et al. In 2005 shows, that final year resident physicians, almost about 96% of them, had reported being unprepared or poorly prepared for culturally sensitive care. And this included caring for patients whose religious beliefs were affecting their treatment. And then this study was the Khabarit study, I hope I'm pronouncing it right, which was conducted in France, was particularly interesting because it showed that physicians had low levels of medical awareness of Ramadan fasting, which led to culturally non-inclusive medical advice and the lack of patient education on treatment adjustment. What the authors had observed and reported was that a lot of the physicians were actually asking patients not to fast. So that was not really in tune with the cultural and religious beliefs of the patient, which led to tension or perhaps even non-adherence on the patient's part. Now that led us then to look at diabetes education interventions to improve adherence. So we wanted to look at what is already out there in terms of interventions to improve adherence. And what we found was that diabetes education interventions were crucial aspects to improving adherence. So we kind of zeroed in onto this particular topic, and we looked at some of the key research that was conducted. And here we're going to be talking about 4 of those studies. The first one was conducted back in 2010 in the UK, where they used patient education to help with diabetes adherence. And what was found was that there was a prevention of weight gain during Ramadan, or rather after Ramadan, and a decrease in hypoglycemic events. And the Ahmedani study back in 2012 in Pakistan showed that patient education allowed for a reduction of the number of acute diabetes complications. In India, Delhi, to be more specific, Fatima et al. Had found that patient education on something as basic as lifestyle, diet, and medications before Ramadan was found to increase patients' awareness in relation to their diabetes management during fasting, and also increase in the number of and duration of fasts that were kept, because there were fewer adverse events due to fasting. In a landmark study by McEwen et al. Just last year, with four different countries which were Muslim, dominated, was what they had found. The authors were found were that an educational package that was individualized to the patients was leading to more positive patient outcomes, such as patients being able to modify their diabetes treatment plan, self-monitoring of their blood glucose levels twice daily, so before and after fasts, improvement of knowledge about diabetes complications, and a prevention of weight gain. So all these studies did show that patient education was the key to improving diabetes adherence during Ramadan. Now, what we found interesting, though, was that the Fatima et al. Study was one of the few studies that looked at the cultural aspects, or the culturally meaningful outcomes to patients, which was their ability to increase the number and duration of the fasts that were kept, because they had fewer adverse events. And that was to us very encouraging, because it meant that the Fatima et al. Study looked at not only the medically positive outcomes of diabetes education, but also what was meaningful to the patients. Now, just to give you a brief introduction to diabetes in Hyderabad, unfortunately, our city is the leading, or rather the cancer, sorry, not cancer, sorry, because I do so much of cancer research, cancer just rolls out of my tongue. Hyderabad is considered to be the diabetes capital of India, with 16.6% of the population having diabetes. The risk factors were found to be age, the duration of exercise, family history of diabetes, and the BMI. And research and published outcomes of diabetes were only two studies, one that looked at diabetic retinopathy and one that looked at diabetic kidney disease. Now, just to give you also a background about Hyderabadi Muslims, we have a population of about 30% Muslims in Hyderabad, and the most frequently spoken language among Hyderabadi Muslims is Urdu. And some of the popular cuisine of Hyderabad is Hyderabadi biryani, halim, kubani ka meetha, double ka meetha, bagara bangan, and these are all the foods that are eaten not only during Ramadan, after the sunset, but also throughout the year. And these are extremely rich cuisine. It's very subtle and layered in its spices or in the sweet. They do use healthy ingredients, but it's definitely high on the sweets and the carbs. So, now, kind of looking at all the literature and the introduction that we've been giving so far, what are the aims of our study? So we wanted to look at illness perceptions and diabetes-related self-efficacy, emotional adjustment to diabetes, psychological distress, and religious commitment among Hyderabadi Muslims with diabetes who are fasting during Ramadan. Now that seems like a mouthful, and let me kind of unpack it just a little bit for you. What we found when we looked at the patient education interventions was that they did look at illness beliefs and did look at part of illness beliefs. We're trying to make a connection between how, say, lifestyle modification could improve their well-being, physical well-being, or diabetes-related well-being. And that kind of triggered us to look at how are people understanding, making sense of their illness, And how is that correlating with other psychological variables that were related specifically to diabetes? So we were able to recruit 50 Muslim patients who were diagnosed with diabetes and were observing the fast during the month of Ramadan. The data was collected in 2014, so basically a year and a half ago. And what was interesting to us was that it was super difficult to collect data from these patients. A lot of the patients turned up at the hospital and were in a rush to complete their checkups and leave, and a lot of them left their phone number with our researchers, but most of them did not pick up the phone, or we had recorded an incorrect phone number or something like that. So although Osmania General Hospital sees a vast number of patients, and the diabetes related patients were also huge, we were unfortunately only able to recruit 50 of them. The other limitation was because we wanted to recruit patients during the season or the month of Ramadan. So that again limited us because we couldn't go back and retrospectively interview these patients. We wanted to interview patients who, within a week of, having started they're observing their fast. So we were sort of limited for or constrained in terms of time also. We used 5 different psychological measures. One was the BIPQ, then the religious commitment inventory, the problem area and diabetes self-efficacy scale, and the hospital anxiety and depression scale. I want to elaborate just a little bit on the BIPQ because this is the central focus of our study. The BIPQ comes from or is based on the common sense model of illness representation proposed by Leventhal et al. In 1980, which measures 9 core components that look into the individual's beliefs about a particular health threat. And now these beliefs are gotten from a variety of sources, personal experience, resources for information such as internet, the newspaper, TV, other patients or peers, and also your social network. And the 9 core components look at consequences. So how do they understand this illness to have minor or major consequences? What's the time trajectory or the timeline of this illness? Whether they feel like they personally have the ability to control the symptoms of this illness. Whether the treatment was effective or not in controlling the illness. Are they able to correctly name or label the illness and also associate the symptoms with the illness? What was their level of worry about the threat? The 7th component is how well they understand, how coherent are they about the illness, and then what's their emotional reactions, what's the degree of emotional reactions, let's say, to this particular illness, and also a qualitative type of question that asks what do they think are the causal attributions to this particular illness, and they're allowed to give about 3 potential causes. So coming to our results, we are still analyzing our data. So this is extremely preliminary findings. So we are yet to also, we've got a lot of demographic information which is somewhat qualitative in its nature that we've yet to enter and analyze. So anyway, now with the information that we have that we can relate to you is that we interviewed 50 patients, 12 of them were male and 38 were female. The average age was 46.5 years, and the average monthly income was a little over 7,000 rupees, which is better than the national average. And this is a household income, by the way, not individual income. And the times in diagnosis varied vastly between 3 months to 15 years. And in our preliminary analysis, we were surprised to notice that none of the patient demographical characteristics correlated with any of the psychological variables. We believe this has to do with our tiny sample size. When we looked at our psychological variables, we found that almost all of them were scored at about above the average. So there was an above average or religious commitment, above average on their illness perceptions, emotional adjustment to diabetes, and diabetes related self-efficacy. Patients also reported moderate levels of anxiety and depression. When we were looking at the illness perception subdomains and how they were correlating with each other, we found that worse consequences of diabetes were associated with perceptions of longer time duration, experiencing many severe symptoms of diabetes, and worse emotional representations or reactions to the illness. And perceptions of a longer time duration of diabetes were associated with better treatment control, obviously worse consequences, experiencing many severe symptoms of diabetes, better illness comprehension, and worse emotional representations. Weaker perceptions of personal control over diabetes was associated with weaker treatment control. And weaker treatment control obviously was associated with weaker personal control, but also better emotional representations or reactions. Experiencing many severe symptoms of diabetes was associated with worse illness representation and obviously perceptions of longer time duration and worse consequences. Some of these findings that may appear to be a little different or confounding could be because of our underpowered sample size. And it also could be that there's a huge variation in the time since diagnosis. What was interesting though was that the perceptions of illness-related worry did not significantly correlate with any of the BIPQ domains. And we're yet to figure out why this may be happening. And obviously it could also be because of our underpowered study, but it is also interesting to note the fact that there is no relationship or there's no significant correlation between illness-related worry and the other BIPQ domains. So we'd be open to any of your thoughts on why this may be. When we looked at illness perceptions in relation to the psychological variables, we found that negative perceptions of illness were correlating to all the psychological variables, such that worse consequences of diabetes was associated with better diabetes-related self-efficacy, but increased anxiety. Perceptions of longer time duration of diabetes was associated with increased anxiety. Weaker treatment control was associated with decreased religious commitment. Experiencing many severe symptoms of diabetes was associated with increased religious commitment, poor emotional adjustment, and increased anxiety and depression. Weaker illness comprehension was associated with increased diabetes-related self-efficacy, and worse emotional representations were associated with poor emotional adjustment to diabetes and increased anxiety. So this was... Then we looked at the illness perception domains of personal control and illness-related worry, and we discovered that it did not significantly correlate with any of the psychological variables. Again, we are sort of trying to unpack why this could possibly be, allowing for the obvious explanation, which is the underpowered study. But in conclusion, what we could say from our preliminary findings was that negative perceptions of illness were related to increased religious commitment, poor emotional adjustment to diabetes, poor diabetes-related self-efficacy, and elevated levels of psychological distress, that is, anxiety and depression. And that patient demographic characteristics and illness perceptions of personal control and worry were not correlated to any of the psychological outcomes of the patients. So in conclusion, what we could understand was that the way the patient was understanding and interpreting the illness was indeed associated with how they were cognitively, emotionally, behaviorally responding to the illness of diabetes. So in relation to that, one key implication or encouraging finding for us was that patient education may indeed be beneficial in order to improve improve patients' diabetes management during Ramadan. Some of the education material that can be developed could focus upon Topics such as increasing awareness of the consequences of diabetes, increasing acceptance of the time duration of diabetes, increasing awareness of treatment effectiveness, improving knowledge on identifying symptoms and the corresponding actions that can be taken, and providing skills to identify and appropriately respond to emotional reactions towards diabetes during the Ramadan month. So these are just, as I said, suggestions because these are extremely preliminary findings. Now, there are some obvious limitations to our study, one of which is the small sample size. And we also did not explore the physician's experiences of diabetes management because this is a two-way process between the patient and the physician in that sense. But also because we are from a collective country, we also needed to look at the family caregivers' experiences, often needs in relation to the patient's diabetes management that we were unable to capture in our study. With that, I'm done with our talk for today, and if you have any feedback, comments, queries, please go ahead and email me. And if you have any thoughts on some of our interesting findings, such as the one I was telling you about how illness-related worries was not correlating with the subdomains of BIPQ and with the psychological variables, if you have any thoughts on some of those kind of findings, then please feel free to either leave a comment in the comment box or shoot me an email. Thank you for now, and I hope you have a fantastic weekend.